Good morning, everyone. My name is Rob Cooper. I'm a cardiomyopathy cardiologist based in Liverpool Heart and Chest Hospital. It's a rather unusual platform to be speaking to you today. I much prefer being in a room with you all, but we'll do our best given the current circumstances. I apologise for my background. This is the only room in the house where the kids are unlikely to get me, and I didn't realise you were going to be able to see me this morning. I thought it would all be about the slides. But if you could ignore me and look at the slides, that'd be much better. Okay, so the topic that we've been given this morning is surgery in cardiomyopathy. And there are a lot of things that we can talk about in surgery in cardiomyopathy, probably a lot more than 45 minutes worth. So I'm going to try and focus a little bit on some of the treatments available for hypertrophic obstructive cardiomyopathy, the thickened heart muscle with the inefficient blood flow out of the main pumping chamber. And when it comes to device, a little bit about defibrillators, primarily defibrillators, because that's more common in the world of cardiomyopathy. There are other types of devices, other types of implantable pacemaker devices, but we're going to focus on ICDs. So when it comes to hypertrophic cardiomyopathy, there are several paths that people with the condition can follow. There's a very high proportion of people that don't really have any symptoms from it, are monitored to assess for any risk, but generally do quite well with it. And we see that in this asymptomatic group here. There are a group that struggle with heart failure being, by medical definitions, the inability to get an appropriate amount of blood to the tissues. And sometimes that's due to obstruction. There is very rarely due to low pumping function. That tends to be other types of cardiomyopathy, such as dilated cardiomyopathy. There is a risk of sudden cardiac death with cardiomyopathies, which most people are aware of. The risk is actually very low. It's an unpleasant thing to deal with and to talk about, but reassuringly the risk is quite low. There's also this risk of irregular heart rhythms, the atrial fibrillation, which happens to around 1 in 5 people when they get to the 50s or 60s. So we're going to talk predominantly about the obstruction. This is an MRI scan of a heart, and this is at least near normal. This is my heart, and we're going to try and talk through it so that we can look at the comparison of normal to cardiomyopathy. In this picture, the light grey represents the blood inside the pumping chambers of the heart. And you have 4 chambers. Blood comes back from your body to the right atrium here, goes through a valve into the right ventricle, which squeezes down, pushes blood off up to the lungs. It'll then come back into the left atrium, labelled LA here, through the mitral valve into the left ventricle. And this is where all the hard work of the heart is done, where the force is created to send the blood around the body. You see this dark area here, this is the muscular wall of the heart. Okay. If we think about hypertrophic cardiomyopathy, by its very definition, it's a descriptive term. It means that heart muscle is thickened, hypertrophic, thickened or overdeveloped, cardio, heart, myo, muscle, pathy, problem. And there are lots of different ways in which the heart muscle can be thickened, different patterns of thickness. Here we see that septum, the ventricular septum, the wall between the left and right ventricles, is particularly hypertrophied. In this example, it's the bit at the tip of the heart, the apex or apical cardiomyopathy. Here we see some septal hypertrophy, but it's not quite to the same extent as this, and it's actually quite localized just to the base of the heart. And this is thickness throughout the whole of the main pumping chamber. This is a concentric hypertrophy. So these all fall under the umbrella term of hypertrophic cardiomyopathy and actually represent quite different clinical problems, usually different symptom spectrum. Typically, we're going to be talking about obstruction for the next few slides. And obstructions, it's a bit of a misnomer because the blood was obstructed from getting out of the main chamber, you wouldn't be walking around. There is an inefficiency with the way the blood gets out of the heart, and the outlet area is narrowed. It's not quite obstructed, but it means that the heart has to work harder to get blood through a smaller space. So in this example now, blood's coming back from the lungs into the left atrium, goes through the mitral valve into the main pumping chamber, the left ventricle. Then it's trying to go straight out here towards AO, the aorta. This area, just on the way out, in the base and the septum of the heart, is thickened and hypertrophied, so it narrows the outlet part. You see in the cartoon that when blood's trying to get through this narrow part, it's redirected, and sometimes this ends up with blood actually going backwards towards the lungs, this regurgitation of this valve. And I feel a bit sorry for this valve because it's not really its fault. It given the correct circumstances, would open and close quite nicely. But because there's narrowed area and the blood flow inefficiencies, you end up getting blood going backwards rather than forwards. And the heart has to work harder to do that, so it's inefficient. Left ventricular outflow tract, so that's the part of the heart on the way out, the outflow tract. The obstruction, so this inefficiency of blood flow, is present at rest in around a third of patients. If you provoke people with exercise or sometimes with breathing maneuvers, so those of you who had an echo and been asked to do the breathe down the maneuver, that's called the Valsalva maneuver, might be seen in around 2/3, sometimes up to 70%. Not everybody with obstruction will be symptomatic. Those who do have symptoms, it tends to be breathlessness, so disproportionate breathlessness when you're walking around or you're doing fairly simple activities day to day. You might struggle with your breathing because your body's not quite getting enough blood to those tissues. It can also present with chest pain and can sometimes present with dizziness, lightheadedness, and sometimes blackouts. And the underlying mechanisms for these symptoms are complex and multifactorial, but the symptoms are the same and they're unpleasant. Reassuringly, removal of the obstruction can provide significant symptom relief, and it's one of the most satisfying things to do for somebody who technically has heart failure at that time. You can provide a good treatment to make people feel a lot better, because if you reverse this inefficient blood flow, people notice this a significant difference, and it reverses breathlessness, chest pain, and sometimes this dizziness or blackouts that medics tend to call sync. There's a suggestion that if you treat patients with obstructive cardiomyopathy with things like alcohol ablation and surgical myectomy, they'll have a similar outcome to a normal population long term. And that comes in terms of how long people live and what sort of symptoms they have. Now it's a medical graph, so bear with me. But what I wanted the point that this graph makes is it doesn't matter how you treat obstruction as long as you treat it well. Along the x-axis here is years of follow-up. So starting at the point at which people are up to 10 years here. These lines represent people treated either with alcohol ablation or myectomy, or those who had non-obstructive cardiomyopathy, or those who treated with tablets. Tablets are very effective. And generally you see how these lines track each other. And this tells us about what proportion of people have survived up to 10 years. And actually these lines track not too dissimilar to a normal population if this obstruction is treated well. So it doesn't matter how you treat it as long as you treat it. So how can you do this? The title of the talk is surgery and devices, but actually before all this, lifestyle measures and tablets are really, really important. And simple things like weight loss and adequate amounts of fluid. So a lot of cardiology is about restricting fluid intake. Actually, in obstruction, I want to encourage you to drink more, sometimes up to 3 litres of non-alcoholic fluid a day. Small and frequent meals rather than big meals, so you don't draw the blood away from your circulation to your gut to digest it. Tablets are fantastic. So medical therapy actually works very effectively in an awful lot of people. So before you go anywhere near surgery or devices, you need to have a really adequate trial of taking these tablets. And they tend to take the form of beta blockers, so tablets ending in OLO. Some calcium channel blockers, so verapamil and disopyramide, and thiazide, and a combination of these with disopyramide can sometimes be. And even those who were referred specifically to a hospital that does alcohol ablation to have alcohol ablation, around a third of these can be treated by just adapting their medication. So it's not to be sniffed at. We have to trial medications properly first. When it comes to intervention and septal reduction, so quite literally changing the size of the septum, generally there are 2 options available to us. There are some other things, but I think they are such low frequency that we should focus on alcohol ablation and surgical myectomy. So one is a procedure and one is an operation. Surgical myectomy is the operation. In alcohol septal ablation, the idea is to reduce the size of this thickened septum to open up the outflow tract of the heart. Now, in this simplified diagram, the blue side is the deoxygenated blood, the right heart, and the left side is here with the red, where the blood is flowing around this thickened septum. You take a plastic tube from the wrist or the groin up to this thickened septum and inject alcohol into it. And the alcohol kills the tissue so that it shrinks. And the analogy I often use in clinic is like putting a piece of chicken on a grill. It doesn't go anywhere, but when you kill muscle, it shrinks. This then opens up the outflow. So this thickened piece of heart muscle here, we access one of these blood coronary arteries with a tube, then take a wire down the coronary artery to the very small blood vessel that you want in this piece of thickened muscle in the septum, blow up a little balloon in there, and you then have a connection between this side of the balloon and outside where the operator for the alcohol ablation is, and they can then inject the fluid into here. And we know that it's going to just this piece of heart muscle because it's beyond this balloon and it's sealed, so nothing can go backwards. Now that cartoon looks quite straightforward, but actually the heart arteries are really complicated. Even these ones that you see as big arteries here are 3 millimeters in size, and then they branch out like the branches in between to very small arteries. What you're often looking for in alcohol ablation is a branch down here. So it's several branches down. It's quite small, quite fiddly work. So we try to use a lot of tests to make us better at this, to guide and identify exactly what it is that we're doing. So in this is now a CT scan. And in this example, blood's coming into the bottom of the left atrium through this valve into the main pumping chamber and then trying to go out towards the aorta. This on the way out is really thickened, and this is the target to try and make it a bit smaller, to open up this outflow, to make it less hard work to get the blood out. Now, in this film, you see a flash of light grey here. This is blood inside a coronary artery. And this artery is going right to where we wanted to deliver the alcohol, therefore the damage. You see it highlighted in this freeze frame when the heart is relaxed. Okay. So we know that this is what we want to track, and we can then use software, CT, so computer tomography CT software, to track this, to map it, and then know what we're going to face when we get into the cath lab. So this is another example of the CT picture. This view shows that this piece underneath my cursor here is really thickened heart muscle, and here is the blood vessel going into it. Now we then recreate these same views with an angiogram in the lab. This is somebody's IC, so this is an X-ray picture. And we see that this blood vessel mimics this blood vessel, because it's the same blood vessel. We just looked at it with different methodologies. We then stick this balloon in the artery and deliver the alcohol beyond it. Now this angiogram in the lab, when you're going through the wrist or through the groin, is these arteries. And you can see how it's not that easy to appreciate the anatomy unless you couple it up with looking at the major structure of the heart. Once we've got the balloon in this place where we think we're in the correct place, we will then inject a contrast. The contrast lights up on an echocardiogram, and most people with cardiomyopathy will have had an echocardiogram of some description. This is done to show that we are treating and targeting the exact piece of heart muscle that we want to. Now remember, this is thickened on the way to the heart and the base. And in this ultrasound scan, there's an area here that is really quite bright, has contrast, and that is contrast injected by a tube that's in the wrist all the way to the heart arteries, and then using an ultrasound scan on the table so we can see live exactly what's happening. And because this was exactly where we wanted it to be, in this thickened septum, we injected alcohol. And you can see how it's causing tissue damage already. It's really bright and inflamed. And that's what we want to see. We need to damage that piece of heart muscle. So this is the sequence of events over the course of the best part of 6 months for one of my patients. Here we have an MRI scan where blood goes into the main pumping chamber and out. And this area here in the septum is really thickened, and this is the target. 2 days after alcohol ablation, we can see this really black area because this has been injected with alcohol and it's not getting blood anymore. This is destined to die. It's not shrunk yet. This takes some time. If we then go back at 6 months and take a picture again, you can see how this area that was black and has now been killed and is shrunk back. And then you look at the actual film, the cine, you can see how the outflow part of the heart is much bigger here 6 months later than it was here, meaning that blood can get out, not working as hard, get more blood to tissues, and this is what reduces the symptoms. Much more efficient blood flow. As with any procedure, there are risks of complications, but actually for a deliberately destructive procedure, alcohol ablation has very few risks. The major risk of a procedure is that of very slow heart rates or complete heart block, and that sometimes needs a pacemaker. Internationally, these rates are quoted as somewhere between 5 and 10%, so 1 in 10 to 1 in 20 people will need a pacemaker afterwards. Now, often when you're talking about risks of a procedure and operations, you talk about things like death and damage and need for long stays in intensive care or heart attack or stroke. But when we actually consider that pacemakers are part of an effective treatment strategy for those with hypertrophic cardiomyopathy, it doesn't really fall into the same risk of same category, high risk outcomes. The other risks are minimal. Fast heart rates that are treatable there and then on the table, and unwanted heart muscle damage. The risk of this is less than 1%. And actually, most people with hypertrophic cardiomyopathy have got too much heart muscle. So if you go to this procedure, what to expect? Before you get anywhere near an operator's needles and tubes in the lab, you should have had a lot of investigation to understand and have a very clear plan before you go in there about the approach to this. It's local anesthetic in the wrist and usually in the neck for a temporary pacing wire. It's you awake chatting to the team. When we perform it in Liverpool, you get to be part of the Guess That Tune game, and we have had patients who've beaten some of our cath lab staff, Prof Stables, rather eclectic musical tastes. Procedure lasts anywhere between an hour and a half up to 3 hours. Tubes in the wrist and then usually the neck now. The anaesthetic stings a little bit, like when you've been to the dentist, but after that, it's largely boring. It's us looking at screens, trying to find small blood vessels. Then some performing echo on your chest, which most people are familiar with. Once we are in the correct place, we will be looking to inject the alcohol. Disappointingly, it's not like a tot of whiskey. You don't really feel any general body effects of it. It can cause some discomfort because we are damaging heart muscle tissue, but we have very effective painkillers in the lab. Probably around about half of people will need some painkillers. The other half, it's an irritation, but no more. There's then 10-15 minutes of waiting for it to do its job before we remove the tube. The neck tube will stay in for a day to check that your heart rate does not go too far. Hospital say generally is 4 to 5 days. And we are trying to focus on patient perspective here. So we have actually recorded one of our patients talking through his experience of alcohol ablation. And it was possible to go to the IT team. Stephen, do you know if we're able to play this video now? Video available. Okay, so I don't think you're going to be able to hear any audio from here. So that doesn't hold much merit. So we're going to move on from here. I do apologize. I had sent it in advance. Okay, so after alcohol ablation, we then need to talk about surgery. And this largely involves removal of the piece of heart muscle that is thickened and is narrowing the outflow tract. The phrase for this is myectomy, my muscle ectomy removal, and has a long history of treatment of obstruction out of the heart. And the first diagrams and descriptions by Morrow are just as relevant today as they were then. This thickened piece of heart muscle is chopped off with a scalpel. It's a surgical approach to things. It's wrong. I'm going to cut it till it's better. Now, this is a disclaimer slide. If you are squeamish, there are some pictures in the next slide that may offend you and have made people feel dizzy at patient conferences before. So if you are squeamish, then I'd ask you to look away now or just skip the next couple of slides. Generally, so this is an MRI scan again here. We're looking at this thickened piece of heart muscle here. And the approach from a surgeon is to actually open the chest and open the main blood vessel coming out of the heart and look down into the heart. So the view is to go straight down, looking on top of the piece of heart muscle. Okay, so next slide coming now. So this is the view through the main blood vessel, the aorta. The surgeon looks down, sees this thickened piece of heart muscle, grabs it with a pair of essentially posh tweezers and cuts down into it with a scalpel. It's a little bit shaky-handed, this cameraman, isn't he? I'm glad he's holding the camera rather than a surgical scalpel. But as the surgeon cuts down through this piece of thickened heart muscle, he or she can then remove it, and you see this piece of heart muscle removed from the heart. And that has then got rid of that piece of thickened heart muscle and opened up the outflow tract. Okay, those people can look back again now. Now, myectomy is excellent. It's really very effective, especially done in experienced hands. And the real beauty of it is not just about thickened heart muscle. Often when it comes to the heart, and specifically hypertrophic cardiomyopathy hearts, there are other things that may need some attention. So the valve next to the thickened heart muscle, the mitral valve, the one on the way into the left ventricle, sometimes has some abnormalities, and this can need correcting. So the operation gives us the beauty of being able to cut the thickened heart muscle out, but also adapt the valve, so to repair it or sometimes to replace it. It can also deal with things like heart artery narrowing. So if you need a coronary artery bypass graft, it's best to have this operation done at the same time rather than at another time. Subaortic bands of fibrous pieces of gristle essentially underneath the main, underneath the aorta valve can be removed, and the aortic valve can be replaced. So there are lots of things. The surgery gives you the flexibility to do more than alcohol ablation can do. So in here, this is now an echocardiogram, and blood's going in and out. And underneath here, we have a band on the way out. So it's almost like chalk. And this, even if you kill this piece of heart muscle, will not do anything. It won't make it shrink. It's already thickened and gristle type tissue. So this needs to be removed by an operation. This band just here. The risk of surgery. Now, these are more individualized, and they will come down to a detailed conversation between you, your cardiomyopathy doctor, and your surgeon. There is a greater spectrum of risk in that those who have pre-existing conditions have a high risk of adverse outcome. Now, there is a risk of mortality, so not getting out of the hospital, risk of death, and this is usually in the order of 1 to 2%. There's a risk of a need for a pacemaker afterwards, and this is in a similar realm of around 10%, so not too dissimilar to alcoholation. There's a risk of damage to kidneys around the time of an operation because of the physiological hit that the body takes, but this is usually temporary. There is also a risk of stroke. Again, this is low, but there is the risk that you need to discuss with your surgeon. So there's probably a high risk of immediate complication versus alcoholation. But the beauty of it is it's being refined. Although it has been performed for the best part of 60 years now, we can also plan these operations using models. And we've taken to actually taking pictures of people's hearts and translating it into a full 3D printed model for people these days. So this was pioneered by people who actually operated on the heart, on the printed heart. So there are chunks of muscle taken away here, and then so this is the example used in the 3D printing. And then in the operating theatre, the exact same approach is taken, and cuts are taken of the myocardium, of the heart muscle, so they can plan and know and reduce the risk of complication. So this is something that we started doing at Liverpool Heart and Chest Hospital. So this is one of our first patients. This is a hospital number, so you can't identify them. And we were able to print the heart and open it up and see exactly which piece of heart muscle we needed to remove and exactly how close it was to valves, and for the surgeon to familiarize themselves before they are in the operating theatre. And familiarizing is very important. If you are comfortable with what you're doing, the risks of complication are a lot lower. It helps us understand a lot of other things as well, not just about this heart muscle. There are abnormal connections sometimes in hypertrophic cardiomyopathy, and we are able to see this by opening up the heart, bearing in mind that this is the view that the surgeon will have here, the left atrial view. We're able to know exactly what it is we're dealing with so that he can orientate himself perfectly when he's in the surgical theatre. We then move on with each and go to modelling. And this is a three-dimensional model of someone who has outflow tract obstruction, significant heart muscle thickening, but also this white stuff here is calcium, and this is obstructing the outflow tract further, and this is the sort of stuff that needs to be removed. So we model, we use the software, we plan it, we move around, we know exactly what sort of cuts, how deep, how far, and what perspective the surgeon is going to need when they're in. And this is an example of a model. Now, normally I would hand a model around at this point, but I'm afraid we can't hand things out remotely. But this is an example of thickened heart muscle, and this pink area here is the calcium in this heart muscle. This is stuff that absolutely has to be removed. So the surgeon can see exactly what they're doing. Okay, another disclaimer, please look away if you're squeamish. There are some content in the next slide that may upset you. So this, from the previous model, was the pieces of heart muscle that were removed at the operation. So this is what we planned. This sort of pink stuff is the heart muscle, and this yellowy stuff is the calcium that we saw on the scan and the model. And the surgeon knew exactly how far to cut in because we had the model, and they had a perfect plan for it. And this went quite straightforward, this operation. So what to expect? Now I have another patient video for you. I don't suppose that one's arrived, has it, Stephen? Okay, so I now have to do my best small talk for 60 seconds, which I'm not usually very good at, but I'll try and delay this slide. So the surgery is harder work for you as a patient. It's more challenging to recover from. It involves more discomfort in your recovery from an alcohol abation. Usually by day 2 in hospital, people are wondering what the fuss is about and want to go home, and they're bored and complaining about the strength of the Wi-Fi and they can't stream very well. That's their greatest concern. When it's an operation, there is more cuts, more pain to get over. There is a similar complex workup, and there needs to be some really detailed conversations, both with your cardiomyopathy doctor and with your surgeon, And this is where having a big team of cardiomyopathy experienced people is really important, because you need to be able to have that communication between the cardiomyopathy doctor who's used to dealing with these anatomies and the surgeon who knows how to actually perform the operation. And there are some circumstances in which we can only use surgery rather than alcohol ablation. So this might come up in a consultation with you with your cardiomyopathy doctor, that actually there are things beyond just the heart muscle thickening that need to be addressed, and alcohol ablation can only deal with that heart muscle thickening. This is an occasion when sometimes an operation will be mandated if we want to treat it. It will involve a day in intensive care afterwards, most of which you're not really aware of. It's a little bit groggy. Your family will be more aware of that. The actual operation itself will take around about 2 to 3 hours. You'll be away from relatives for around 5 to 6 hours with the anaesthetic beforehand and the recovery time after. Thank you. There is usually a week in hospital, and you go home between 5 and 7 days. And although you've gone home, you're not quite your normal self. Sometimes there's a bit of discomfort with the chest. Sometimes your normal systems, like your sleeping and your appetite and your bowels, aren't quite ready for a few weeks. But normally, by a month or so, you're back towards some semblance of normality.
I've been treated for hypertension since 2007. I was a regular gym goer, and I started to notice a decreasing exercise tolerance over the years, which was rather subtle and slow moving, and you were wondering, have I really got a problem or not? In 2014, as it happened, I was abroad examining at the time. I had an episode for a few hours of atrial fibrillation, which gave me palpitations due to an irregular heart rhythm, which resolved after a few hours. In the spring of 2015, I had a further episode which lasted for much longer, about 3 weeks, and I saw my GP, who referred me to a cardiologist at the Royal Liverpool. The next thing that happened was in October 2016, I was on one of my laboratory inspection visits, and I had an attack of central chest pain pulling my heavy suitcase up the ramp at Euston Station in London. And it struck me that this was an angina attack. So as soon as I got back home, I went to see my GP, who referred me for investigation, and Liverpool Heart and Chest was the only hospital in the area that was offering appointments in a reasonable time. And I was actually seen there within 3 weeks of going to the GP. The coronary angiogram was normal, and my echocardiogram was abnormal, and as well as showing changes of hypertension, there was asymmetrical hypertrophy of the left ventricle, and he said he thought I may have hypertrophic cardiomyopathy. He then arranged for an MR scan to be done, which was done right at the end of 2016, and this confirmed the diagnosis. So, having confirmed the diagnosis of hypertrophic cardiomyopathy, I was then referred to the Inherited Cardiac Conditions Clinic at Liverpool Heart and Chest, and was seen by Dr. Cooper. He explained to me that although I had a single underlying condition, basically hypertrophic cardiomyopathy, I had a number of physical problems, including atrial fibrillation, obstruction of the left ventricular outflow, and deteriorating mitral valve function, but they could all be fixed at a single complex or multi-stage surgical procedure. So he referred me to Mr. Pullen with that in mind. Before I saw Mr. Pullen, he arranged for a cardiac CT scan so a 3-dimensional model of my heart could be made. It certainly makes things easier to understand. I was in a privileged position being what I am and having the knowledge that I have, and I think it was very easy for Dr. Cooper and later Mr. Pullen to explain to me exactly what needed to be done and what was going to be done. But for a layman, I think it would be hugely helpful in the sense that the 3-dimensional anatomy is difficult to understand, let alone what goes wrong with it and how it can be sorted out. So yes, I think it was beneficial to me, but it will be even more beneficial to a member of the lay public. In the clinic, Mr. Pullen showed me exactly where the thickening was by allowing me to introduce a finger into the aorta of the of the model, so I could feel the constriction for myself, and he explained what muscle he was going to remove to sort this out. Things went fairly straightforwardly from there. I ended up having to have a pacemaker because a significant rhythm abnormality was detected on a couple of occasions when I had a week's ECG monitoring. But other than that, everything was really gone very smoothly. I felt well enough to go back to work part-time at the Royal Liverpool in November and December, following which I finally retired. And I was referred for cardiac rehabilitation to the unit at St Cath's on the Wirral, and I've still a couple of weeks to go to finish that. But I feel better than I have done for probably 3 years. I've walked several miles without difficulty. I'm enjoying the gym exercises, and I intend to go back to my old gym once it's finished. I think I'm lucky to be alive now. Personally, I feel I was deteriorating very quickly and wouldn't have lived much longer without the treatment, and now I can look forward. I can't speak too highly of it, really. I mean, I was looking at a terminal illness, and now I'm looking at having a fruitful active retirement.
Perfect. Okay, I hope that worked for everyone. Our patient there was actually a pathologist, so was very familiar with anatomy and took great. I think he really felt the benefit of being able to understand the anatomy and look at his own heart. Anyway, so back to, should you have alcohol ablation or myectomy? Well, ultimately, that's a decision that only your team can make because it's based on your individualized anatomy. When well chosen, the outcomes in terms of your symptom resolution are comparable. The survival to length of follow-up in alcohol ablation is similar, but bear in mind we've only been performing alcohol ablation since 1994 and operations and art like this since about 1959. So the long-term survival data is more full for myectomy. Your team will make individualized recommendations regarding your choices, and ultimately bear in mind that you're the most important person in the decision-making process. Your team will guide you, give you risks and likelihood of success, but you need to be involved as well. So, outflow tract obstruction from the left ventricle is associated with greater burden of symptoms. Treatment can be very effective in improving symptoms, potentially improving the prognosis. Tablets should not be underestimated. They're very important, and we should maximize these before we go anywhere near you with procedures or operation. And place the local strength to septal reduction. Sometimes some centers will have surgeons who are very well versed in these operations, but not people to do alcohol ablation, and vice versa. Okay, so rather than stop the questions there because we're not in an interactive audience at the moment, I'm going to move on to defibrillators and then do some pre-planned questions. So what is an ICD? It's an implantable cardioverter defibrillator. It's a shock box, essentially. It's a pacemaker style device that looks like this, with leads that sit inside the heart, monitoring your heart the whole time. Most commonly, these are transvenous, not always, sometimes they're subcutaneous, but it tends to be that they're underneath the collarbone, usually on the left side. The wires go into a vein, hence being called transvenous. Veins all lead back to the heart, and the wires sit inside, usually the right atrium and the right ventricle. On an X-ray, this is what a transvenous ICD will look like. So this is the box up here, and these are the wires going down inside the heart. A newer kid on the block, the subcutaneous ICD, is a device where the box is a similar size, but it goes on the left side of the chest, outside the rib cage. So it's underneath the skin, so subcutaneous, and with a wire tunneled outside the rib cage again, up here. And then you can deliver a shock between the tip of the wire and the can here. And this is very similar to an automated external defibrillator and holds the benefit of not being in the vein, so it doesn't pose the risk of as many long-term complications with regards to having something inside your vein. All tissue that is not naturally biological and is inside the body will eventually start to have some reaction to. So if it's inside the vein, it can cause more problems. So the major benefit of this is proposed to be that it's outside the vein. So why would somebody need a defibrillator? Secondary prevention, if you've had one episode of a very fast heart rhythm of ventricular tachycardia or ventricular fibrillation, then we want to make sure that a second one isn't as dangerous for you and you have that safety blanket of defibrillator. Sometimes it's primary prevention. So we identified that there is an unacceptably high risk of having a ventricular hernia and put this in before anything happens, and it's a decision between you and your team. How does it work? Well, generally there are two methods of action for a defibrillator. The first is one that you might not be aware of, and it might sense that the heart rate is going very fast, let's say 170 beats a minute. The device will then pace your heart faster than that rate. So let's say 200 beats a minute. So it's now taken over and is pacing your heart at 200 beats a minute. That will only do it for a matter of a few seconds, and then will slowly ramp down. So that brings it down to 180, 160, 140, 100, and then back down to normal and then stop. So it overdrives or overrides the fast rate, bringing it back down to normal. That's called anti-tachycardia pacing. Anti-tachycardia just means fast heart rate. And the other mode of action, which most people are more familiar with, is defibrillation. It's electric shock generated to restore a normal. Will people know we have an ICD? There's usually a small scar at the site of the implant, just underneath the left collarbone in most people. The box may protrude slightly. Now, even though these things are subtle and you may see them, it's important that you do not fiddle with your defibrillator to reduce the risk of having any infection, to reduce the risk of the way that the wires and the actual box can work. So once it's there and it's settled, please leave it alone. Why would you get a shock? Your ICD is continually monitoring your heart rhythm, and it's programmed to only deliver shock if it detects a life-threatening heart rhythm. Now, if your heart's going fast or irregular, then you'll often feel unwell beforehand because your blood pressure will drop and you feel a little bit uncomfortable. So you may feel unwell before a shock is given. There are some circumstances in which we need to consider whether you can set off and have an inappropriate shock. Now, it's unlikely, and programming is much better now than it was previously. So most of these devices are set to only act with a heart rate of greater than 200 beats per minute in young people, and you've got to work pretty hard to get a heart rate of 200 beats per minute. Even on exercise tests, most people won't mount anything near that. So it's almost always safe to get excited, to exercise, to have sex, to have an argument, all of these things. If you're having an argument, you don't need to hold back. You need to go at it, make sure you win that argument, okay? Your ICD is programmed to recognize these. Can you exercise with an ICD in general? Yes. I think it's important that exercise is part of the lifestyle modification of all patients with cardiomyopathy, okay? Everybody should be doing some form of exercise. It's important that you know your heart rate limits on your device. And so this is a conversation between you and your team again. If you are going to exercise, try to avoid direct collision. So if team sports are your thing, then there are vests available that can try to protect it. Even with the best will in the world, vest and a scrum in rugby might not go very well. So be sensible about your sports choices. Now, this is an example of a football player who played in the Belgian league who has an ICD. You see this man here who's collapsed to the ground. It's Anthony van der Loos. If you watch very closely now, see that little jerk? That's his ICD shocking him out of a dangerous heart rhythm. And there we go, he sits back up. So it was very effective. So there's several take-home points from this video, which is available on YouTube if you want to hear the crowd. Firstly, the physio was there and was on him and was touching him and considering doing CPR, and the shock was delivered and he did not get no harm. If you have a cardiac arrest, people around you know that they can touch you. Secondly, it acted pretty quickly. And he was able to get up and sit up, and he actually wanted to play on. He was advised against it very wisely, but he felt it for himself almost immediately. So ICDs in sports, there are sports people with defibrillators. The only way we can comment on whether it's safe to have this is to observe those people who have taken a choice between them and their team, so shared decision making, that they'd like to carry on playing sport with a defibrillator. So there are a few hundred in registries, around 2/3 are males, around a quarter were teenagers. Most sports that are commented on are running and soccer. I don't call it soccer, I'm from Liverpool, it's very much football. Basketball, which again is down to the Yankees. So in these registries, nobody died when playing exercise, nobody suffered a shock-related injury, but 1 in 10 got a shock during sport over 2.5 years, okay? 8% got a shock from the device outside of sport as well. And 10%, 1 in 10 had a problem with the leads at 10 years. So there are some risks to consider. They're not catastrophic risks, but they're things that need to be out in the open early on so that you can make an educated decision about these things. What to do if you get a shock? It's safe for someone to touch you if you're having a shock. It's very easy to say this in the context of a presentation from the attic in my house, but we try to relax and stay calm. Find somewhere that you can sit or lie down comfortably and try not to be alone. Tell someone around you what is happening, okay? Contact your team if it happens and complete a device download. Most people have remote monitoring these days. If you feel unwell, then you seek medical assistance. If you have another shock, you go straight to A&E. So exercise intensity by condition. So we've mostly spoken about hypertrophic cardiomyopathy in this presentation, but there are, of course, many different forms of cardiomyopathy. I tried to list them here. So along this line is hypertrophic cardiomyopathy. So can you do light exercise with hypertrophic cardiomyopathy? Yes, absolutely. You should, absolutely must. I'd recommend it at least every other day, ideally every day. Can you do moderate exercise with hypertrophic cardiomyopathy? Well, probably actually. There was a good trial called Reset HCM a couple of years ago that suggested that if you're working to moderate intensities in exercises such as a treadmill or an exercise bike, it's almost certainly safe and makes people feel better. Can you do hard exercise? Well, this has been a big no for many years. I think people are becoming more realistic with hard exercise and hypertrophic cardiomyopathy. And there's some very useful, very early, but very useful research presented a couple of weeks ago from a team in London about high intensity training and hypertrophic cardiomyopathy. And it was fantastic. It was really great to see the people exploring these avenues. So for now, it's difficult to recommend this, but we're certainly looking to more research projects targeted at getting people more active. Arrhythmogenic cardiomyopathy have to be a little bit more restrictive. You should still be walking and talking and getting some light exercise every day. Probably not for moderate intensity exercise and certainly not for hard exercise. With dilated cardiomyopathy, the shackles are off a little bit actually, and I would recommend to do exercise every day. And we're probably looking at being able to do hard exercise as well. If you have a defibrillator, we have to consider those aspects of training as well. So at this stage, I'm going to go to some questions which have been pre-populated. I don't know the exact format for this, Christy, but I have the page open on my phone. So if it's okay, I'll just go through a few of these questions until you stop me. Is that all right with you? Silence means a yes to me, so I'm going to carry on for now until I'm stopped. Okay. So, is ablation the only surgery for ventricular tachycardia? So ventricular tachycardia is complicated, and it depends an awful lot about what is the cause of ventricular tachycardia, how frequent it is, how fast it is, how debilitating, what medications you're on, what results from blood tests will allow other medications. The mainstay of treatment is medical, is tablets. And if someone's proposing an ablation for you, I would suspect it's because the tablets aren't controlling it as much as they should. There are also some settings on defibrillators that can be changed to try to prevent these sorts of things happening. And it's a difficult thing to answer definitively, and I appreciate that might not be the answer that that you wanted. It is very much an option, and in well-chosen people is an effective option. It's best done in centres that do a good volume of ventricular tachycardia ablation, because it's not the most common form of ablation. So it is an option, and in terms of surgical intervention, it's probably the option. Okay, so now we're on to this question about CRTD. So the caller has second box and battery runs a few years regarding the third. Can't be specific, but generally what factors that could affect the ongoing replacements, and how do we envisage improved battery technology possibly extending the working life of CRTDs? Yeah, good question. So technology moves on rapidly, and the size of the boxes and how long they're there is pretty much defined by battery technology, by how long they can last and how small they can be. The other complicating factor with devices is the leads that are in the heart, and that's less reliant upon battery technology. And the longer the leads are there, the greater the risk of some complication. With each box change comes, so taking one box where the battery is depleted and replacing it with another box, there comes some risk associated with it. And your team will be able to detail that a lot more accurately. Generally, there are people who get multiple box changes and do quite well with them, and I wouldn't worry too much about it. At this stage, battery technology is improving and devices are smaller than they were and generally will last longer, but we're still looking at quoting around about 10 years for the battery of the device, depending on how frequently it's used. And the slight issue with this question with the CRTD, so cardiac resynchronization therapy, is that most devices that are put in are working all the time, so they're pacing the heart as well at different places, so that depletes the battery. They have a greater strain, so generally they tend to last not quite as long. is there a limit on the number of ablations you can have due to the damage changes it can make to the heart wall, which is often the reason for the original VT? Okay, good question. So VT, ventricular tachycardia, or the fast heart rate, is sometimes related to underlying scar in the heart. And it depends on what type of ablation we're talking about. If it's alcohol ablation, then the evidence would suggest that it does not increase the risk of you having ventricular tachycardia and actually reduces the risk. Now, it's not perfect evidence, but I feel reasonably comfortable in saying that it won't make things significantly worse. Okay. If we're talking about a different type of an ablation, so a VT ablation, electrical burning ablation to treat VT, generally these things will reduce the risk. So all ablations should be aiming at to reduce the risk of VT recurring. Thank you, Stephen. I'll get through as many as I possibly can. My doctor warned me if my ICD makes a rumbling sound, I should contact him. I've also been told that I will still have heart failure, so wonder whether I should have another battery. I feel ambivalent regarding having a device that the cardiologist thought was helpful. So if it is a defibrillator without any resynchronisation therapy, then disappointingly, it doesn't really make people feel better in terms of the symptoms because it doesn't improve the pumping function. It does, however, provide a safety blanket that if dangerous events happen, it will shock you out of them. Most people who have a defibrillator still won't have a shock, and it's really difficult to predict accurately and discuss what level of risk people are willing to accept. Generally, cardiologists get a little bit twitchy once we perceive that the risk of something life-threatening happening to patients being more than 1 or 2% per year. Okay, the risk is cumulative. So although we're uncomfortable with 2% per year, still over the course of 5 years, that risk might only be 10%, 1 in 10. So most people won't necessarily get shocked, but it's there in case you do, and should provide that psychological boost that you can do the things that you want to without fear of this thing happening to you because you have your safety. Thank you. This is a good one. I am nervous about having my pacemaker replaced with an ICD. The operation, can you tell me anything about the operation? So the operational procedure, because it's usually done under local anaesthetic, is very similar to having a pacemaker. The box is slightly bigger, the leads are slightly bigger, but the upgrade is very similar to an experience that people have with a pacemaker. So it's a little bit of sedation beforehand, which I'm told feels about 2 or 3 gin and tonics, so it takes the edge off, but you're still awake. Then local anaesthetic over the skin, and then the operator doing their bit with an incision, one box out, another box in. It usually means that you're in theatre for somewhere between an hour or two, depending on how complex it is. Then you're stitched up and go back to the day ward usually. These things are normally done as a day case, so you don't even need to stay in hospital. I have an S-ICD which is switched off as Entresto made a massive improvement to my heart. Fantastic, I love Entresto. Should I have it removed, or what about the batteries? So that's complicated, and I wouldn't want to make overarching statements without understanding the real detail to what's going on. Some people with dilated cardiomyopathy, I presume this is dilated cardiomyopathy, have a fantastic response to medications, and the risk is much lower, the pumping function is higher. And you can discuss having it out. Now, the longer it's been there, the more risky it is to have it out. And there's an argument to say that it provides that safety, that backup. So it comes down to how much you want it out, how long it's been there, how secure the improvement in your heart function is, and how safe we are in saying that it's not going to deteriorate again in the future. These are things to consider with your cardiologist and have these conversations in a clinic or on a telephone clinic at the moment. Disappointed. Thank you. So HHR, sorry, should I explain that? Heart rate reserve 70%. So this is down to the difference between your peak heart rate, your resting heart rate. So that's your heart rate reserve, and then 70% of the way from your resting heart rate up to your peak heart rate. And that's the way most exercise trials are guided now. So I don't have enough time to explain it now. It's probably best to Google heart rate reserve. And last one, I've had my ICD for 11.5 years on a second battery. How long do the leads usually last? The leads themselves will last for a very, very long time. The thing that your doctors will be aware of is the longer that the leads are there, it can cause some irritation to the veins. Now, most people get away with it just fine, and I certainly wouldn't be worried at 11.5 years. The leads are generally very, very good, and most leads that were dodgy have now been replaced with ones that are much safer, under much greater scrutiny. So I wouldn't worry too much about the safety and strength of the leads themselves.